So Emma, you are the boss. So when you want to start, we can start, and so you can present Dr. Shin
Yeah, I think
for today's.
let's go ahead and start right now. So again, good
Okay.
day everyone, and welcome to another DCB Academy session. It is my great pleasure to introduce Dr. Doosup Shin, an interventional cardiologist and assistant director of research at St. Francis Hospital and Heart Center in New York. He is an expert in intravascular imaging and the management of complex calcified coronary lesions. We are really delighted to have you with us here today, Dr. Shin, to lead the session on calcified nodules in PCI. The floor is all yours.
Thanks for kind introduction and thanks for having me today here. It's a great pleasure to meet all of you. I'm going to present the calcified nodules, especially for the interventional cardiologist, but also to understand its unique disease entity. I think it's important to understand some degree of pathogenesis and pathophysiology. So we're going to go over all these things today briefly. So calcified nodule is a distinct type of calcified lesion characterized by dense calcified fragments protruding into the lumen. It is one of the most challenging subset of the lesion in PCI. As shown in this study, presence of calcified nodules significantly increased the risk of MACE after PCI compared with those without calcified nodule. To understand the unique pathobiology of calcified nodule, it is essential to first look at their pathogenesis. From autopsy studies, it's been hypothesized that calcified nodules originate from the necrotic core calcification, where an area that lacks collagen. Over time, the calcification begins at the edge and the outer wall of the plaque, and it gradually progressed inward, eventually replacing the necrotic core. Histologic studies also have shown that this collagen deficient necrotic core calcification, shown in B in this histologic segment, often sandwiched with rigid collagen-rich calcified sheets with a greater tensile strength. And this is important because mechanical force from the hinge motion are believed to play a key role in the development of the calcified nodule. When the vessel undergo hinge motion, the torsional stress concentrate on the fragile area of necrotic core calcification without collagen, leading to disruption of the fibrous cap and intraplaque capillaries, which in turn promote the further progression of the nodule. These processes can lead to the rapid progression of the calcified nodule, causing acute luminal narrowing due to overlying thrombus formation or intraplaque hemorrhage, and eventually acute coronary syndrome. However, if the fibrous cap remains intact or if the previously disrupted fibrous cap heals over time, calcification may continue to propagate into the inner portion of the calcified nodule through the osteogenic transformation. And this results in a more mature, stabilized form of calcified nodule, which can sometimes cause a chronic coronary syndrome. These hypotheses were supported by our recent study of 372 untreated calcified lesions with serial OCT over time. In this study, 7% of the untreated calcified lesions eventually develop a new calcified nodule over the median follow-up of 1.5 years. When we looked at the factors associated with the development of the calcified nodule, attenuated calcium indicating lipidic or necrotic core, higher calcium volume index suggesting the presence of large calcified sheets around, and the large delta angle on angiography suggesting a hinge motion, all independently predicted the development of de novo calcified nodule on follow-up OCT. In addition, left main bifurcation, where plaque burden is high with high tensile stress and repetitive hinge motion, and the patient undergoing hemodialysis were associated with the development of calcified nodules. In addition, other studies also demonstrated that calcified nodules are frequently found in the area where necrotic core are more frequent and where there is increased torsional stress, such as proximal to mid RCA or in the left main bifurcation, especially the proximal vessels. So in summary, calcified nodule originates from necrotic core calcification without significant collagen. However, it's sandwiched between rigid calcified sheets with a lot of collagen. Mechanical force due to hinge motion may play a role in the development of calcified nodule. And then calcified nodules are frequently found in distal left main bifurcation or proximal to mid RCA. And it's also frequently found in patients with CKD or undergoing hemodialysis. With this pathogenesis background in mind, it is important to understand two subtypes of calcified nodules. So eruptive nodules have a disrupted fibrous cap, often with the overlying thrombus. They are thought to be more biologically active and perhaps earlier manifestation of a calcified nodule. Eruptive calcified nodules are recognized as one of the causes of acute coronary syndrome, accounting for about 2 to 8%, depending on the study. Also, these eruptive nodules are what early pathology studies described as calcified nodule, typically as a cause of sudden cardiac death. So traditionally, calcified nodules were referred to as this eruptive subtype. Whereas non-eruptive nodules, which was previously referred to as a nodular calcification in pathologic studies, have a smooth fibrous cap without overlying thrombus. See in the intravascular imaging as well. They are considered to be less biologically active and more mature form of calcified nodule or healed form of calcified nodule. And it can cause chronic coronary syndrome depending on the luminal obstruction. Now shifting gear to diagnosis and treatment, one of the challenges in calcified nodule management is its diagnosis. Angiography is helpful. When you see this angiographic radiolucent mass, the presence of the positive predictive value of the presence of calcified nodule is high. However, sometimes it is challenging to differentiate calcified nodule from thrombus, especially in the setting of acute coronary syndrome. In fact, eruptive nodules are often associated with overlying thrombus, so they are somewhat overlapped. So especially in the setting of angiographic severe calcification, calcified nodules should be considered when you see the angiographic radiolucent mass. However, the absence of angiographic radiolucent mass has limited negative predictive value. And also, 36% of calcified nodules are not detectable by angiography. So in this case, there was a angiographic calcification, but there was no obvious angiographic radiolucent mass. So plain balloon angioplasty was attempted, but it's not able to dilate. Later, the OCT revealed that there is protruding non-eruptive calcified nodule in this area. Therefore, their use of intravascular imaging is important, especially when you are dealing with a severely calcified lesion. When it comes to the treatment, it is important to understand the concept of deformability. This was actually our case, and there is a radiolucent mass in the osseous circumflex where you see a lot of calcified nodules. And intravascular imaging confirmed that there's a non-eruptive protruding calcified nodule. In this case, we did NC balloon angioplasty, and the balloon symmetrically expanded with guide wire in the middle of the balloon. And this suggests that the nodule is deformable. And final OCT confirmed an symmetrically expanded stent without advanced lesion preparation. As shown in this case, investigating the balloon response is probably the most effective and practical way to test for deformability. If your balloon is not fully expanded, you should consider advanced lesion preparation prior to placing any metal to prevent stent under expansion. As shown in this case, stent was placed with suboptimal result due to non-deformable calcified nodule. Often we use IVL in this kind of cases as a bailout strategy. However, that's not ideal because IVL energy can be limited by the presence of metal between the balloon and the lesion, and also it can technically damage your polymer. And so it's better to prep the lesion before you place a stent. The type of calcified nodule matters when it comes to deformability. From the Doosup CAD study, we learned that majority of the eruptive calcified nodules are deformable. You can think of this as a broken glass on jelly. So broken glass is calcified fragment, and the jelly underneath consists of softer components such as fibrin, lipid, necrotic core, where it originated from, and intraplaque hemorrhage from the disruption of capillaries from the calcified fragment. So with the balloon angioplasty, you might actually push those broken glasses of calcified fragment deeper into the softer component inside, effectively redistributing the calcified nodule. In contrast, non-eruptive nodules are not always deformable. Think of this as a marble sitting on the top of the rock. So marble means a larger segment of calcium, and inner side, there are a big chunk of calcium from the osteogenic transformation of intraplaque hemorrhage. And in this case scenario, balloon angioplasty may not be able to deform or push the protruding part of the calcified nodule away. Some non-eruptive nodules are deformable based on Doosup CAD study. We call this as a marble on jelly. So if you think about the pathogenesis, until the nodule is fully matured, it may still contain softer material inside with fibrin, necrotic core, and lipid. And you can imagine that you can push this fragmented calcium away from the lumen into the softer portion, resulting in the adequate balloon expansion. Here are some case examples of non-eruptive nodules. The case on the top showed that the nodule was deformable and you achieved a good post-PCI outcome. However, in the bottom, this is non-eruptive, non-deformable calcified nodule with the asymmetric stent expansion at the end. We have been scanning cadaveric human coronary arteries with micro CT with 0.2 micrometer of resolution. And we recently found some examples which may support our hypothesis. On the left suggests non-deformable non-eruptive calcified nodule or marble on the rock, where you see the chunk of calcium base of this calcified nodule. Whereas on the right, it may suggest a deformable non-eruptive calcified nodule or marble on jelly, where you see fragmented calcium within the heterogeneous material, most likely fibrins, lipid, and intraplaque hemorrhage. Unfortunately, traditional intravascular imaging cannot help to determine the deformability, since you cannot see effectively beyond the calcified nodule and you don't know what's inside. Considering the limitation of traditional intravascular imaging to determine the inner component of the calcified nodule, we hypothesize that something like NIRS may help us understand what's inside of the nodule. Here is the case where we identified the calcified nodule in the left main. In this case, we used the OCT NIRS, and we found the non-eruptive calcified nodule, but behind there was a lipid signal. We interpreted this as a marble on jelly configuration, suggesting that softer material, such as lipid, was present within the nodule itself. And in fact, the enhanced angiography also suggests that there's a dense calcium interspersed with the less dense area with yellow circle, suggesting the area of lower calcium density within the nodule. In this case, under the enhanced angiography, we performed the balloon angioplasty, and then we revealed that the compression of the dense radiopacity to the less radiopacity area in the yellow, resulting in a sectal balloon expansion. And stenting was successful with acceptable MSA of 12.1, confirmed the deformability by IBUS without advanced lesion preparation in this case. Now with the emerging topic of CT-guided PCI, we also try to see how coronary CT can help. These are the micro CT, photon counting CT, which is the most advanced CT technology that we have, and conventional CT on the same cadaveric artery in the same slice. In micro CT, it's obvious that this is not just a chunk of calcium. However, clinical CTs really cannot say the features of calcified nodule, even with the most advanced photon counting CT. It appears like one piece of calcium. One thing that might help in this situation is Hounsfield unit. And then relatively low Hounsfield unit may suggest the presence of heterogeneous material in the calcified nodule, suggesting the deformability. And then the one that I showed earlier, in this case, the Hounsfield unit was much higher, potentially suggesting marble and rock situation, and then maybe less deformable compared to the prior one. However, this is still under investigation, and we need to learn more about this. Now we'll talk about treatment challenges. As we discussed, balloon angioplasty remains a very practical way to test lesion deformability, but it does come with the challenges. It can lead to the eccentric balloon expansion, dissection, and elastic recoil, which may limit the effectiveness of or increase the procedural risk. In the cadaveric study, we observed that dissection after high pressure POVA typically occurs at the interface between the eccentric calcium and the adjacent non-calcified vessel segment, as clearly demonstrated in this histologic section. If balloon angioplasty is not enough, advanced lesion preparation like rotational atherectomy is performed to debulk the calcified nodule. However, it's important to remember that the rotational atherectomy outcomes are heavily influenced by the guide wire bias. If the guide wire bias is favorable toward the lesion that you want to modify, RA can effectively shave the nodule, and often seen in the OCT, there's a concave groove. However, the wire is away from the lesion that you want to modify. You cannot really affect the calcified nodule or modify the calcium. The rotational atherectomy predominantly ablate the contralateral wall, leaving the nodule largely intact and increase the risk of complications. Orbital atherectomy is considered to be less affected by guide wire bias because of this eccentrically mounted crown with the circumferential shaving mechanism. In this case, we initially performed a rotational atherectomy to the non-eruptive calcified nodule, but it did not really effectively modify the lesion because of the unfavorable guide wire bias. Subsequently, orbital atherectomy was performed, which resulted in more effective debulking of the calcified nodule. However, orbital atherectomy performance is still influenced by several factors like RPM, speed of advancement, and number of passes. So even with the optimal technique of 1 millimeter per second of advancement or withdrawal of the crown at the higher speed, the maximum arc that you can ablate is less than 2 millimeter, meaning it is still subject to guide wire bias and perhaps lumen size. And we actually look at in our OCT database, and orbital atherectomy in the setting of lumen size less than 2.5 millimeter, we were able to ablate close to 40% of calcified nodule. However, if your lumen size is more than 2.5, you cannot really modify the calcified nodule, and then we're only able to debulk about 16% of the calcified nodule. Intravascular lithotripsy is theoretically not affected by guide wire bias since it's the balloon-based strategy. And IVL works for the calcified nodule by generating the fractures of the calcium. Even if you don't see obvious fracture line on post-IVL OCT, the micro CT actually confirm the importance, confirm the fracture of the calciums, confirming the importance of balloon angioplasty following IVL to confirm the deformability. can see there's a fracture line, clear fracture line in calcified nodule and also adjacent calcified sheets after IVL therapy. IVL performed similarly in the calcified lesion with and without calcified nodule. So although there is a numerical difference, and we know that calcified nodule has a worse outcome after PCI, but still in this study, there's no statistically significant difference. And also there is comparable effectiveness between the lesions with calcified nodule and without calcified nodule after IVL therapy when it comes to the OCT variables. We also compared IVL with orbithoratherectomy in our calcified nodule database. The procedural and clinical outcomes were comparable. There was no major difference between the minimal stent area, and also there's no major difference in target lesion failure at 2 years. These results support the use of IVL for the calcified nodule. We often use a combination strategy as well, typically atherectomy to shave the top of the calcified nodule, and then IVL to break the calcified nodule. Lastly, I will briefly talk about paradoxical outcomes. As I mentioned earlier, eruptive calcified nodules tend to be more deformable, while non-eruptive calcified nodule may not be. However, so this resulted in actually the better stent expansion with the eruptive calcified nodule. However, studies have consistently shown that the target lesion failure after PCI is much higher in eruptive calcified nodule compared to non-eruptive calcified nodule, despite better stent expansion. This is likely because eruptive nodules are more biologically active, and patients often present with acute coronary syndrome rather than stable disease. One of the major failure modes, particularly common in eruptive calcified nodule, is reprotrusion of the nodule. In this case, PCI was initially done successfully with excellent angiographic and OCT results. However, during follow-up, there was only reprotrusion of the calcified nodular material leading into the reformation of calcified nodule within the treated segment in 10 weeks. Lastly, it's important to know that minimal stent area is often outside of the calcified nodule. In this study, we found that about 40% of MSA occurred at the site of the maximum calcified nodule, suggesting that majority of the MSA was actually not in the area of maximum calcified nodule, but perhaps in the adjacent collagenous calcium. So the lesion prep should not be limited to calcified nodule, but to the entire calcified lesion to achieve the best outcome. This highlights the importance of intravascular imaging in the management of calcified lesions. Calcified lesions was a unique subgroup from the Illumian 4 trial, where intravascular imaging led to significant reduction of target vessel failure and serious MACE after PCI. So in summary, calcified nodule subtypes have unique features, treatment response, and prognosis. Assessment of deformability of calcified nodule is important. And it's important to understand the immediate treatment response may not always align with long-term outcomes, especially when it comes to eruptive calcified nodule, where you have a better stent expansion, but perhaps worse long-term outcome because of the patient-level risk factors and the reprotrusion of the calcified nodule through the stent's roots. The presence of heavily calcified sheet adjacent to calcified nodule, often resulting in MSA outside of the calcified nodule. So the lesion prep really should be done in the entire lesion, not just focusing on the calcified nodule. And last but not least, the patient-level cardiovascular risk factors commonly associated with the calcified nodule, such as chronic kidney disease, and this patient requiring aggressive GDMT to improve the outcomes. Thank you for your attention, and if you have any question, please feel free to reach out to me. Thanks.
Yeah, thank you. This was an amazing lesson, probably the best lesson I've ever listened to on calcified nodule, because it went from pathophysiology to treatment, back and forth. And this is the only way to deal with this very complicated setting. And also because we don't know, this is probably the highest mountain that we have to deal with for the next future in interventional cardiology. So thank you really for the quality and also technical hints that you put into your presentation. And also thank you for avoiding mentioning the jingle effect. Do
Yeah.
you know what I'm talking about?
No.
That's
I'm not sure about that, so but
no, that's a
yeah.
mark of Ziad Ali, and he did the
Yes.
live case. We're talking about the jingle effect, and
Yes, there's a lot
we
of
always
debate.
laugh. Yeah,
Yes.
it's a lot of debate, a lot of debate. And Jeremiah is actually is not doesn't agree with him.
Correct. Yeah.
Yeah, well, that's fun. So, no, I have a question. So, are you aware of any data? Because, okay, of course, we are interventional cardiology. So, when we see a calcified nodule, we want to be aggressive. But you have shown that once you balloon a lesion, there is often no way back. You have to finish whatever you start. But are you aware of any data about the regression of not the calcified nodule itself, of course, but on the consistency of the calcified nodule? Or is it there any retrospective large data set analysis that is showing how that specific drug or combination of drugs can go, into, transform a calcified nodule into a more like a jelly marble type from a fully marble one?
That's actually a very good question. But unfortunately, I don't think that there's any data out there, anything can actually, make the calcified nodule less, rigid or, more favorable for PCI. Unfortunately, when you think about the pathogenesis, it's the opposite way. Usually it's a softer material and it's getting matured and it's getting harder as a natural process of the disease progression. Yeah, I'm not aware of that. However, I think it's going to be great if we can make this, calcified nodule a little less rigid so that we can have a better outcome. But yeah, I'm not aware of any drugs that has been shown to actually make this reverse this process and make the PCI favorable.
Yeah. Okay, thanks. Guys, please,
But
questions.
thank
I
you
think there are many of them.
thank you for interesting, very interesting presentation. I have the question. We know how to treat de novo calcified nodules, orbital, rota, IVL. We have all of those equipment. However, in my opinion, now we have big problem with patients which we already treated. So we implanted stent, and under the stent there is calcified nodule, and those patients could have only two types of treatment: off-label IVL, off-label laser. So, what's your opinion on that and about the outcomes of those of those patients?
Yeah, so your question was specifically on the reprotrusion cases, right?
Yeah.
For example, ISR due to calcium. That's actually a very good question, and we know if there's ISR because of reprotrusion of calcified nodule, their prognosis is like probably worst. They tend to do very well no matter what you do. So first of all, I think it's important to prep as much as possible before you place the first stent. However, as I showed, it's not uncommon that you have a reprotrusion of the material through the stent. So first of all, in my personal opinion, try to avoid any metal in the calcified nodule. I use physiology most of the time if I really need to treat the calcified nodule because I know the prognosis is not good. When it happens, I think there's a lot of debate. Sometimes, as you mentioned, we do IVL to see whether we can push that away and then place another stent, or DCB is one of the options. I don't think that there's any evidence out there saying that DCB can be helpful in this calcified nodule situation, but I think that it will help. The problem is it can still reproduce no matter what you do. I think there was some discussion about the cover stent to like really see whether they can help to prevent the material to regrowth inside. But again, that's not that's just an anecdotal kind of case report from the Japan, where they use the cover stent to that kind of area. Sometimes, we do stent ablation. We do like atherectomy to really debulk that reprotrude part, or actually, if the stent was underexpanded, we do like stent ablation to really get rid of those part. But again, I think IVL, laser atherectomy. I mean, you can use multiple different lesion prep, but for now, I don't think that there's any like proven effective treatment option in that kind of situation. And then unfortunately, the risk of their target lesion failure after reprotrusion of the calcified nodule often reaches to like 50%. So it's very malignant disease. I think it's better to avoid any intervention if possible, but if it's truly causing problem, I think, we're stuck. There's no single method to really prevent this thing happen again and again. So I think there's more study needed. And then also I want to understand whether initially doing DCB in that area and avoiding metal can be a good option. Obviously, one thing is the recoil is probably a little more common, if you will, in the calcified nodule after balloon angioplasty. So that's one of the things that we need to think about. Whether after you do the balloon prep and then do the see whether there's any good lesion prep,
Maybe
and then you can do DCB or
Yeah.
not. Yeah.
maybe
Yeah,
bioadapter
but
stent in such cases.
Excuse me?
Maybe bioadapter stent.
Yeah. Yeah.
Maybe.
yeah, so the DCB is theoretically more appealing than putting metal. I agree. But you still have to shave and crack, because DCB on a marble doesn't work like any other tool. We presented the preliminary results at TCT of our studies called Cardiac. Daniela presented it, and it's a severely calcified lesions treated with atherectomy or IVL plus DCB, no stent. It's a small study, 121 patients, and I don't currently remember the exact number. Maybe Marco, if he's still here, can remember the exact number of calcified nodules. But if I remember right, there are around like 30 or 40 patients with calcified nodules, atherectomy or IVL plus DCB with a follow-up. And so maybe this sub-analysis can give us more information. But of course, we need more data in a larger population.
Yeah, that's actually very interesting. I think that's worth publishing, or at least show in the community how the atherectomy IVL followed by DCBs. What's the effectiveness of that treatment option in calcified nodule, and definitely worth looking at it, that subgroup analysis. Yeah, that's very
Yeah,
exciting.
sure.
Yeah.
Now we will present the final data, I think, at CRT with the whole population and the follow-up, and then we can, go into the details.
Yeah, and I completely agree with Dr. Cortes, because the drug will not gonna do it that much if there's still like chunk of calcium. If there's a calcified nodule, the drug of DCB will not gonna go into the media. So yeah, you need to prep the lesion still and shave and perhaps crack the calcium as much as possible, so that we can optimize the effectiveness of DCB treatment for sure.
Yeah.
Dr. Shin, thank you very much. Very nice talk. Bharat here from Singapore. One of the things that I think maybe you didn't cover, because it's probably not available outside Japan, it's DCA followed by DCB. So directional atherectomy. I think our Japanese colleagues have started to do it with calcified nodules. And because you can actually use the balloon to direct the blade, towards the nodule and shave off some of the nodule, they're having quite good outcomes if you follow it up with the DCB. So you cut and you shave. It's laborious and it takes a lot of a lot of time and meticulous Japanese planning, but
Right.
the results seem impressive. So
Mhm.
I wondered if you've come across that. I think Nipro are planning to bring the device outside Japan, probably 2026 or 2027. I've heard. So
Mhm.
I mean, it could be another avenue for us to prepare lesions where we don't really then have to worry about wire bias or
Mhm.
cracking the nodule.
Yeah, that's actually a fascinating concept. As you know, it's not available in the US because of the safety concern. But obviously, if you plan the a procedure well, and obviously, theoretically, it's appealing. Now, whether we have enough evidence to do that, I'm not sure. But theoretically, I think that's one of the potential options to really kind of shave as much as possible, and then coating the drug. I think that's probably ideal situation if we can do perfectly. And thank you
Yeah.
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 One other
Another
question.
point.
Sure. No,
Oh,
go
yeah.
ahead.
Please.
Just in terms of, some people say you haven't shocked the nodule enough. Maybe use a second IVL. If cost wasn't an issue, is there a threshold? 80 shocks per nodule or 140 shocks. Is there a point where you say you've tried 120 shocks, it's not budging, move on? Is there a threshold for nodules, eruptive versus non-eruptive? Yeah, I wonder what your thoughts about that is.
Yeah, I think we now in the US we use C2 plus. We have 120 purses, and then one of the things that we have done is really kind of locate the emitter of the IBL, and then really kind of meticulously position that to the area where you really want to deliver the maximum purse. Because if you see the energy from the IBL, around the emitter area is actually the highest energy that you can deliver. So maybe using the advanced angiography tools if you have, and then really place that emitters in the around that area, move a little bit forward or backward to really maximize the effectiveness of IBL. And also another thing is the financial issue. It's very difficult for us to use two IVL catheter in one case in US, unless you want to invest a lot of money. However, usually I think after 120 purses, that's probably maximum benefit that you're going to get. Another thing is IVL is great, but it has also limitation. If you have a thick calcium, it may not be able to deliver the energy, will not be able to deliver the entire, to the deeper portion of the calcium. Another thing is, if you have a like thick fibrous cap between the calcium and the IVL, no matter what you do, all the energy will be absorbed by the fibrous tissue and not delivered to the calcified nodule. So, there's multiple things that you can consider, but I don't think that, beyond 120, I'm not sure whether you're going to get additional like professional benefit from doing more purses compared to the money that you investigate to the case. Maybe it's not, you're not going to achieve like major difference after, more shots. I'm not sure whether you have any experience with that, Dr. Cortes, if you have any like personal experience, whether you use like much more purses and, achieve the better outcome.
No, no, no. To be honest, I've never done that, and it will be interesting to see how the new IVLs that are coming out will can affect it if the way they deliver energy is more effective or not. But I
Mhm.
think that this answer will not be, well, this question will not be answered for the next years.
Mhm.
It's going to be difficult to have, a large experience and to say, okay, this is better than the other. But so I had a question related to a case actually that we are publishing. It's an interesting case on the evolution of this disease, because when you see a calcified nodule in a cath lab, you have to deal with it and you see how it is now. But as any other thing of the body, it changes within the time. So this is a lady that had a non-eruptive calcified nodule diagnosed. And after a few years, she came back with this calcified nodule becoming eruptive.
Oh.
Okay,
Mhm.
so we have OCT images. So from non-eruptive, stable, marble to eruptive. And I'm telling that because we have the OCT, we treated it, it was a left main with a stent. After 2 months, patients came back with the protrusion of the eruptive calcified nodule into the left main. It protruded. And then this patient, and you know, the recurrences of that is so high, and left main. So calmed down by cardiac surgery, she was in another hospital, in another system. They gave her medical treatment. Medical treatment failed. And then she came back to us. And then I did another PCI. I did IVL, though it was an eruptive calcified nodule, but there was no way to expand it well. And then put another stent. And in the last 2 months, patient didn't come back. 2 months follow-up. So this is to say that 1, it's very difficult to deal with. 2, it may change within the time. And 3, it's difficult to categorize eruptive or non-eruptive, because also an eruptive can be difficult to expand well, because probably it was a non-eruptive prior.
Right. Yeah, I mean, probably it depends on when you actually see the nodule, right? As you mentioned, eruptive, initially there will probably no eruption at the very beginning, but as you mentioned, as time goes, the internal material can kind of, erupt the fibrous cap and cause like acute coronary syndrome or became eruptive calcified nodule. So I don't think that we can kind of definitely say, which one comes first and which one comes later. It's sometimes very difficult clinically. But from the data that's available, most of the time, eruptive is a little more softer. However, even after excellent PCI, it tend to come back again. Not sure what kind of comorbidity that patient had that you dealt with. But these patients are sick usually. They are diabetic, they have CKD, they have other, comorbidities that can contribute to their worse outcomes. So from the patient level perspective, not only the calcified nodule, but also patient tend to have a lot more comorbidities that can contribute to worse outcome. And it's very challenging to treat those kind of patients in general.
Yeah. Okay, guys, any other question for Dr. Shin? All right. So, Eman, if you want to close.
Yeah. Thank you on behalf of DCB Academy and everyone here. Thank you for your insightful presentation. It was a delight to have you here. And thank you everyone for attending. Right.
A real pleasure. We learned a lot. Thank you, Dr. Shin. Really appreciate
Thank you very
it.
much. Thank you. Bye-bye.
Bye-bye.
Thank you so
See you.
much.
Bye-bye. Thanks a lot. Bye-bye.
Silence that makes a woman replay in her head that most men never left. It's moving.
Amit, please mute yourself. Amit. Okay, sorry.
No worries. Yeah.